So this is a story about, again, I told you I'd tell Italian jokes. So this is a story about the famous Enzo Ferrari. Okay, Enzo was the founder of the Ferrari Motor Company and the designer of most of the Ferraris. And he finally got old enough to die. And he went to, he was in his 90s, he goes up to heaven, and he's in the antechamber of heaven. And St. Peter comes out and says, Enzo, he went right past all the other people waiting there. Enzo, you wouldn't believe how we've been waiting for this day. God is such a fan of yours. He really wants to see you. He wants to see you now. Enzo's like, huh? So he's rushed into this room, and there on the throne is God. God comes down off the throne, shakes his hand. Says, Enzo, I can't tell you how beautiful the Ferraris you've made have been, and especially the Testarossa. I don't know, that is the apex of your creation. It has these beautiful curves. It slips through the wind so smoothly. That beautiful camel color, the red. It's just beautiful. And Enzo's just beaming at this point. God himself is telling him this. So then God says, but there is one thing. When I sit at the seat and I put my hands on the steering wheel, there's that stitching in the back of the steering wheel. It's kind of rough on the fingers. I mean, really. Enzo at this point is no longer smiling. He's actually quite incensed. I don't care who this is. Says, he composes himself. He says, well, God, I don't want to thank you for being so nice about the Macaw company, but I too have some things I want to talk to you about. God says, oh. God sits down. I want to talk to you about this creation you make. He said, she's called a woman. It's a beautiful thing. The beautiful curves, the way she slipped through the wind, the beautiful hair, the eyes, the bazumbas, everything is wonderful. But there is one thing. God says, what's that? How on earth and why in the hell you put the ignition key so close to the exhaust pipe? I'm sorry. So, with that said, I think I got everybody back. We have a good lineup for y'all. One of my favorites, again, probably almost every one of our meetings, if not every one, is Dr. Deeg up at the Fred Hutchinson Cancer Center. And he has one of the few people, if you look at all our pictures over the years, it looks the same today as he did 20 years ago when we came. He's been instrumental in not only our conference here, but in many of the patients we've referred over the years to him for transplant. And a lot of times, one of the reasons that a lot of our transplant patients aren't here, some of them may be, but a lot of them aren't because they're essentially cured, some of them. I have one the other day who forgot about these meetings, but he wanted to say hello to you, Dr. Deeg, who we had sent to you. So that's not the case for everybody. There's challenges in all of our therapies, but again, without much ado, I'd like to invite Dr. Deeg up to the podium to talk about the role of transplant for MPN.
Thank you. Good afternoon. It is afternoon. Everybody has had a good lunch. I am, of course, honored of being invited again and consider it a real privilege to be here. These patient conferences have been very inspiring. And I think not only patients, I think many of us investigators who don't deal with all aspects of the diseases have learned quite a bit already this morning. Terrific. But I will try to stay on time. I heard that John got his boots upgraded during lunch break, so want to be careful with that. So myeloproliferative disorders should be an excellent indication, of course, for transplantation. It's a proliferating cell disorder, and proliferating cells are typically very sensitive to cytotoxic therapy. Clearly a plus. The extensive scar formation, in parentheses, in quotation marks here, reticular fibrosis, color chain, and even the formation of osteosclerosis is, we have shown that, others have shown that, completely reversible. So one should be able to really return a patient's bone marrow and blood forming abilities to normal, having eradicated the underlying disease. You have heard a lot about this, and I will not spend much time on except to say that as we look at patients and the disease is considered to be progressive, low, intermediate 1, intermediate 2, high risk, thank you, disease, maybe I should stay over here, yeah. We obviously look more and more seriously as a more definitive treatment. I will, however, that goes without saying, incorporate some of what you have heard already about non-transplant therapies into the decision-making process for or against transplantation. I have added here at the very end, sort of, it doesn't really officially exist yet, but Ruben had generated a preliminary draft of a molecular international prognostic scoring system, and I think that's clearly where we are heading, and you have heard some of that this morning. However, extramedullary disease, such as portal or pulmonary hypertension, which are not included in the current risk classification schemes, increase the risk of non-relapse mortality and morbidity, of course, after transplantation. So above and beyond the accepted classification schemes, we need to look at every patient from that perspective as well. And one example is shown here from one of our patients, a liver biopsy showing sinusoidal fibrosis associated with extramedullary hematopoiesis. So in the liver, clearly, and you have heard about that as well. But from the transplant point of view, that becomes important because next to the gut, lung, and liver are the most sensitive organs in regards to toxicities related to the conditioning regimens that we may observe after transplantation. So often, if we have a patient with advanced disease with these manifestations, we may not necessarily decide not to proceed with transplantation, although we should do that at time, but really modify our approach in the direction of a reduced intensity regimen. One other example is shown here. This is a bone marrow, and I think Serge mentioned it this morning, in the lung. We biopsied that, and we had another patient, we thought he had a fungal infection, but it turned out really intrapulmonary hematopoiesis, and this compromises, of course, the ability of the lung to withstand the side effects of transplantation. The basic question, therefore, is really transplantation, no, or when? Now, this is the result, part of the results of a collaborative studies with our European colleagues, Nick Kröger being the lead author here, looking at the DIPS classification and trying to determine in comparison between transplanted and non-transplanted patients who did fit into these 4 risk categories. And the broken line represents the survival in patients who were not transplanted, the solid line survival in patients who were transplanted. And as you can see here in the upper 2 panels, clearly the non-transplanted patient, on average certainly, had a better chance of long-term survival than did transplanted patients. Now, I should immediately point out, however, that goes back 30 years to the very beginnings of transplantation, and as I will hopefully be able to show you, results have improved substantially. Nevertheless, even in this old data, if we look at intermediate 2 or high-risk patients, everybody in the community agrees that those patients are likely to benefit from transplantation, as difficult as the decision may be at times. Now, these are more recent data from our own center, 5 years ago already, but time is flying. And these are patients, 170 patients, whom we transplanted also over a long time span, as you can see the bottom axis here, in years. Low, intermediate 1, 2, and high-risk disease. And these patients showed what nobody was surprised by, that if you had a low-risk disease assessed pre-transplant, you had a higher probability of post-transplant survival than if you had a high-risk disease. It was a clear spread between those risk groups. This late death here was unrelated to the disease. The patient underwent surgery and died from anesthetic/surgical complication. Now, what was surprising, however, was what is shown here. The reason why patients with more advanced disease didn't do as well, and I did emphasize already what the problem is, was because of non-relapse mortality. It's not that the disease came back, but because of all the other organ involvement, lung, liver, I showed you examples, the toxicity was much higher, and that seemed to be more likely, not surprisingly, in patients with more advanced disease, intermediate to a high-risk disease. So there was a striking difference in regards to the possibility or probability of dying from complications after transplantation. Now, one question, and I touched on that already as well, is are we doing better if we use more modern, reduced intensity conditioning regimens? There is one example on this slide that Vikas Gupta, who is located in Toronto, summarizing a large amount of data from multiple centers. And what is shown in the various curves here is the probability of survival, the solid curve here, the probability of survival without relapsing, PFS, and conversely, the upgoing curves, the incidence of non-relapse mortality and the probability of of relapse after transplant. So what you can see after these reduced intensity regimens, they avoid early toxicity. The non-relapse mortality in this end is clearly lower, but the probability of relapse was substantially higher. In our study, it was about 12%. This is, as you can see, as high as 40%. But a big difference also is multiple institutions, rather a single institutions, and I'm not beating here our own drums, but it is true for so many studies. If you concentrate on a disease and the research goes into it, results become better rather than doing one occasionally. So on the background of what was presented this morning then, is there a place for JAK2 inhibitors or other new agents in transplantation? Well, there are potential benefits. One is in regards to engraftment, the pace at which the donor cells can establish themselves in the patients, in marrow, and repopulate marrow and blood. And if we can reduce the spleen size, as happens in many patients on JAK2 inhibitors, we do get faster engraftment. It is not a dramatic difference, but it shortens the time during which the patient is left with low counts and a reduced capacity to fight off infection. The performance status, a lot has been said about that. Patients feel much better and may gain weight, etc., and have a better quality of life, and therefore may have a better baseline from which they start into transplantation. Let me say right here, of course, this brings up important questions. Patients will respond, and many of you will say that, well, I'm doing fine, why should I have a transplant? We'll try to come back briefly. Now, is graft versus host disease affected? Whether it is really less of a problem, graft versus host disease being this immunological reaction, the attack, if you wish, of the donor cells against the patient, even with a perfectly matched donor, sibling or unrelated, other than an identical twin, and few of us have identical twins. So, but we don't know that yet, and I will show you studies are ongoing. However, there is pretty good and rapidly growing evidence that using these inhibitors to treat GVHD, if it develops, may be very very effective. And I touched already on treatment-related mortality. If there is a better performance status, we may have, to start with, we may have a better overall outcome after transplantation. So we hypothesized, in other words, we postulated that treatment with a JAK inhibitor given before a transplant will reduce the non-relapse mortality without increasing the risk of relapse, which is always sort of the bottleneck we have to go through. There are three options. If clinical improvement or stable disease are achieved on JAK inhibitor therapy, maybe one should proceed to transplantation right away. That may be the best scenario. Or should we delay hematopoietic cell transplantation as long as patients show benefits from the therapy, and something got lost here, and consider transplant only if they lose a response or the disease advances. And that is basically the third point. Should one keep treating as long as there is no evidence of progression to leukemia, and treat only at that point in time? I will show one example too, and as you heard already, outcome is certainly not as good. There are limitations, however, of ruxolitinib there are limitations we have heard about. There are also limitations in the context of hematopoietic cell transplantation. The disease may indeed persist, and even though the patient may symptomatically be improved considerably, there is lack of improvement or even worsening of cytopenias, so transfusion may become an issue. Atypical infections have been observed. I don't want to overemphasize that, but once again, if we are heading into a transplant where immunosuppression is a big issue, then we would certainly want to minimize the risk for activating any latent infections. And I'm not sure everybody will agree, but I don't think the data indicate that there are any reduction in the risk of leukemic transformation, so that final scenario still is looming out there. There have been 4 small studies published which are not in full agreement, and the numbers of patients enrolled in those studies, as you can see here, are small. They're all retrospective with all the limitations, just looking back on what did we do and how did the patient do. There are some enthusiasts and some very skeptical colleagues in the field said, well, we need more prospective studies. We cannot really assess at the present time how we should utilize these check inhibitors when we look at patients who are transplant candidate. This is our currently ongoing study that Rachel Salid is leading. And basically all patients are supposed to get the JAK2 inhibitor. If the spleen is very large, based on some of the Italian studies, we may consider splenectomy, although let me say right away, I'm jumping ahead, that our latest analysis, which I will show you, does not show a benefit of splenectomy, which had been postulated earlier, benefit for post-transplant outcome. And I will not go through all the steps here. I mean, they have to qualify, of course, for transplantation with a matched, related or unrelated donor, or they can get umbilical cord blood as a source of stem cells, and dependent upon patient age and what the donor is, different regimens are being used to prepare the patient for transplantation, reduced intensity or high intensity regimens. There are other factors, and that was also discussed already, or at least briefly this morning, in the so-called DIPS plus classification, and the factors that are added there are listed again here: unfavorable carrier cytogenetics, red cell transfusion dependence, and the platelet count below 100,000. All factors that are relevant in the setting of transplantation. And so the latest analysis we have done, that is unpublished data, and I will not bore you with these long, lengthy slides here. I have just 2 of them, and I highlighted a few which I think are relevant parameters. Age ranging from 12.9 to 78 years, a median 54 years of age. About 60% had primary myelofibrosis, and 40% had fibrosis developing after ET or PV. And the classification in the DIPS plus is shown here. The majority of patients had higher risk disease, although 15% would go into lower intermediate risk disease. And here are the transplant characteristics. We had actually more patients who were transplanted from an unrelated donor, most of them being matched for the so-called HLA, human leukocyte antigens, and 46% from related donors. Most of them, 99%, were fully matched. And there was, I think, 1 cord blood, which is shown here. And in most instances, patients, these are the developments over the last decade, or more than a decade now, received not stem cells pulled out directly from the bone marrow, but harvested from the blood circulation after treating the donor with G-CSF in general, Neupogen, you may know that name better, that is utilized to increase the blood cell count, white blood cell count, but also has the ability of basically dislodging the stem cells into the circulation where we can collect them in a procedure we call leukapheresis. And here are some of the results. As I said, they are unpublished so far, but it's close to final. This here is progression-free or relapse-free survival, if you wish, by risk group. Again, black line is the low-risk patients. There was a number, as I showed you, blue, intermediate 2, and red is high-risk disease. A clear separation in 233 patients. Clearly, if you have good risk disease, you have a good risk, and if you have poor risk disease, you have a poor risk. So this is true for so many studies, indicating, however, and sort of forcing us to look at all that again, and with the question, can we develop also non-toxic but more effective regimens for those patients? Here is the incidence of relapse, and there is a slight difference, as you can see, between the high risk in red and the other groups, but as I had already emphasized before, a difference in relapse was not the major reason that patients with high-risk disease did less well than patients with early stage or low-risk disease. Here we looked at cytogenetics, which are of course part of the DIPS Plus classification, and the black line reflects results in patients with favorable cytogenetics and blue in unfavorable. We won't go through all the details, they are listed down here, and relapse was somewhat higher, or p-value, as you know, we like to see less than 0.05, and in fact it was in blue patients with high risk unfavorable cytogenetics. But non-relapse mortality, as before, was highest in patients with advanced high-risk disease and lowest, about 20% over many years, 15 years are shown here, in patients with low or intermediate 1 risk disease. Age is a factor, although it has become less of a factor than it used to be some 15 years ago. In black here, why 54 years? That was the median. Half of the patients were 54 or younger, half of the patients were older than that. So in the older group, patient in blue, there was a lower probability of surviving without relapse compared to the younger patients. Now, we touched already on progression to leukemia. Should one wait until progression to leukemia? I think most of us will answer that question with no, one probably should not. However, there are recent data that under certain circumstances that may be an option. What shown here are factors that seem to be associated before leukemia develops with a higher risk of leukemia. Low platelet count, thrombocytopenia, higher blasts in the peripheral blood, higher risk, non-favorable cytogenetics, refractory to transfusion or refractory anemia, not responding to other manipulations, and then the so-called triple negative subgroup, also mentioned already this morning. In other words, patients who have neither the JAK nor the calreticulin nor the MPL1 mutation. This is just one example by a German group showing outcome in patients who were transplanted after their myelofibrosis had advanced to leukemia. As we heard earlier, the probability of that happening may be in the range of 20%, thereabouts. And in the upper panel here, you see the overall survival and relapse or progression-free survival. There was not a big difference in the end. However, this is sort of not very honest, because overall survival and progression-free survival did differ dependent upon whether the patient's disease did respond to treatment before transplantation. So leukemic transformation, what are we going to do? We give chemotherapy. Is the patient responding? Excellent. And the results are, in fact, in this small study, quite encouraging. Is the patient not responding? Should we go on to transplantation anyhow? Well, it may be the only option, but the outcome certainly is worse. And there are a couple, there's another study from MD Anderson as well showing similar data. And then we have heard a lot about mutations, which, as I said, are not part of the official classification at this point in time. You have heard a lot about these, and these are data published from Europe showing that these mutations are likely to be relevant for the outcome after transplantation. Calreticulin mutated had the best outcome, 85%. JAK2 MPL1 mutated triple negative has the least good outcome in this study as well. And here, once again, why the differences, and if you allow me for simplicity's sake to call triple negative high risk and calreticulin mutation low risk disease, it is, again, non-relapse mortality more than relapse that makes the difference. So there are, and that has been emphasized repeatedly in the literature and this morning, there are clearly other factors that we have not fully recognized. I will touch on one or a couple in a moment, that affect the biology and the pathophysiology of the disease, in other words, determining how the disease behaves and advances. And these are, don't let me confuse you by this slide, but it looks very colorful, so I thought I'd put it in. Emily Stevens generated that in a limited number of patients. Each column here represents a patient, and each line findings in regards to the mutation in particular genes which are listed down here. And you have heard about TET2, for example, this morning, ASXL1. So in other words, we had this number of patients who had JAK2 mutation, and in addition had these mutations shown below. Then we had this number of patients with calreticulin mutations, either type 1 and type 2, without going into that much. Dr. Mullally is certainly much more competent in addressing that, and the additional mutation. And here patients who had other mutations, but none of the others, so triple negative patient. And then Emily looked at how at least some of these mutations impacted transplant outcome. Now, this is not the 233 patients I showed you before. This is, I think we had a total of 58 patients when she analyzed that. So in red shown here is the probability of relapse-free survival in patients with low/intermediate risk disease in that DIPS classification. And one of those patients actually had an ASXL1 mutation, but this is not the patient who died. The patient with the ASXL1 mutation is in fact surviving. And then we have in green patients who were negative for the ASXL1 mutation and patients who did have these mutations, but were in the higher risk, intermediate to or high risk group. And once you get to the more advanced diseases, certainly in our analysis, this the additional presence of this mutation did not make a significant difference. However, I'm not sure it has been touched on this morning. It appears that the presence of ASXL1 in a patient with a background of ET may be very, very different from the prognostic relevance of that mutation in a patient who starts out with primary myelofibrosis. So more work is necessary there. And this is, in addition to this ASXL1, does the number of mutations play a role? And the short answer is probably yes. Again, nobody will be surprised by that. Let's start at the bottom. Green and blue are intermediate to or high-risk patients. These have 3 or more mutations, blue, and these are patients who have only 1 or 2 mutations, and clearly they do better. So the mutational burden, if I may use that term, is also a factor to be considered. And this is an attempt at showing or not whether it is indeed, ASXL1 is indeed a relevant factor. Now this is, and this is a lazy approach, lumping primary and secondary myelofibrosis. As I said, we are still working on that. And what you can see here in the green box is patients who had the ASXL1 mutation were more likely to have the ASXL1 mutation if they had high-risk disease, and they were more likely to have that mutation if they had blasts, or I should probably say the other way around. If the ASXL1 mutation was present, the patients also had higher proportion of blasts, so additional factors that impact the outcome after transplantation. And as limited as the number of patients are, we thought it was quite interesting how the number of mutations impacted survival after transplantation. So 2 or less or 3 or more mutations. Survival beyond 1 year was clearly higher in patients with fewer mutations, 79%. So this takes all risk groups, and I think this is important to recognize. So almost 80% survival, even if you had intermediate to a high-risk disease, if you did not have 3 mutations or more. Deaths from non-relapse causes, I have said that often enough now, that is a major factor, again suggesting biological relevance of these mutations, and relapse was more frequent in that population as well. This is controversial, and maybe one of my colleagues who talked already will comment on that. There is evidence in the literature that the number of mutations also affects the likelihood of response to ruxolitinib. But as I said, this are not my data, and there is some controversy about that. Nevertheless, another factor to be taken into the equation when we have our conversation with patients about the possibility of transplantation. And so just to show that the field is moving here as well, Emily Stevens, who did the other work, is actually a co-author on this paper, where we have started to do single-cell analysis in patients with myeloproliferative disorders. I will not go through the figure over here, but this very colorful picture shows you various populations of cells in blood, and in addition to the different colors, we can then pull out individual cells in which we do sequencing for the various genes. And the idea, of course, is to determine whether immunological factors play a role, pro-inflammatory, inflammation plays a role in the progression of the disease. And I think the environment is the microenvironment, the lining cells of the bone marrow, etc., come into play as well. So I will summarize here and try a few conclusions. I think it is fair to say that transplantation is has highly curative potential for myelofibrosis. The safety has improved. The day 100 mortality, sort of a landmark that transplant doctors are using, which used to be 25%, not too long ago, is clearly down below 5%. Results with HLA-matched unrelated donors are equal to those with sibling donors. I did not show you an example of that, but there are curves in our hands. The survival curves are superimposable. Appropriate for many patients with advanced MDS and some patients with earlier stage, as was also mentioned, younger patients in particular, other risk factors, even if they are not considered in the DIPS classification. And in our hands, the DIPS Plus had higher discriminative power, could better distinguish the different risk groups than the DIPS classification. Comorbid conditions have to be considered. I mentioned just a couple, for example, liver fibrosis, and I showed you the picture of the lungs, other diabetes, kidney function, and so forth. And interestingly enough, some psychiatric disorders have a negative impact on the likelihood of a patient undergoing a successful transplant. I did point out that ruxolitinib may alter the transplant outcome after transplantation, and we do see very good data in the treatment of GVHD. Multiple studies are currently ongoing. The mutational load impacts the outcome. I showed you those examples. And I think we have to plan better in incorporating newly available drugs into the overall package that we offer, the menu for patients, rather than just sort of adding them on ad hoc. So we need a better strategy in doing so. So I would like to thank by name a few people, some of whom I mentioned, and of course, all of you and those who have undergone transplantation. Otherwise, I couldn't show you that information. Thank you very much.